Okay. Dr. David Frank is a medical sociologist and associate research scientist at New York University's School of Global Public Health. His research examines opioid use, people who use opioids, and medication for the treatment of opioid use disorder, or MOUD, often by pointing out the role of drug policy and outcomes generally positioned as resulting from, quote, addiction. Dr. Frank's research also benefits from his own lived experience as someone who uses drugs and who has been on methadone maintenance for more than 20 years. This combination of scholarly training and real-world experience gives his work a unique perspective from which to investigate and understand substance abuse issues. David, thank you so much for joining me today. I'm just so excited that you could be here and that we can have this conversation.
Oh, my pleasure, and thank you for that wonderful introduction.
Oh, thank you. Thank you for providing it. I just I don't even know where to get started here. I'm just so excited to speak with you. I guess I should start, if you don't mind sharing a little bit about your journey and entry into this particular field of study. What drove you to want to get into this?
Well, it was completely tied to my own experience using drugs and on methadone. Shortly after getting on methadone maintenance, and this was about maybe 2004 when I got on, uh, after becoming kind of stable and getting my life together, which did not take long, by the way, I started reading about methadone, about opioids, about drug use, both scholarly and lay descriptions. And I was incensed, particularly with the scholarly stuff. I was like, oh my God, none of these people really get it. They seemed there was this huge distance. It felt like none of them had ever maybe met anyone on methadone or who used opioids. Uh, and that really impacted the way they theorized treatment, the way they describe methadone. To be specific, I really didn't like that it was always talked about in a very medical uh, idiom, a medical lens. It was always described as like an addiction treatment and it was for recovery. And they used this very medicalized kind of language. Whereas my own experience was far more practical and pragmatic. And the experiences of the people I saw around me were also, I mean, there's diversity. I make that caveat. People use methadone for different reasons at different times. And, there's a lot of different kinds of people using it. But in general, I felt like the people I saw every day were using it as a survival strategy for how difficult it is to be a criminalized drug user in the United States. It wasn't so much that people were like, oh, I want to treat my addiction. It was like, my God, this is an unsustainable lifestyle. I'm always late on my rent. I'm dope sick every day. I can't go to school. I can't hold a job, and therefore I'm going to go on methadone. And that was sort of not really acknowledged, and that impacted the policy, the way we think about methadone. It becomes very much of a top down, punitive kind of system. And I wanted to really describe an alternative view, a more realistic view, I thought, of how people used methadone, how people benefited from methadone. But I knew that they wouldn't really listen to me unless I sort of had a PhD. And it was actually kind of comical. I was living in Chicago at the time, and I happened to have got my undergraduate degree at DePaul in Chicago. And not long after getting on methadone, I'd seen some videos on I guess YouTube or something like that of people that use drugs in Chicago. And most of the videos, of course, on YouTube are very sensationalistic and awful and terrible. But this one by this particular filmmaker, his name's Greg Scott, were really good. And I ended up commenting. And it turned out that he was a professor at DePaul. Not only that, but he was a person who had used drugs, used heroin. And we got to talking, and he was like, well, look, there's such a lack of this perspective of real world, of people with lived experience in the scholarly space. He's like, why don't you come back to DePaul, get your master's degree? You could work for me at my Center for Drug Use at DePaul. And I was just like, it was like Cinderella. I was like, oh, okay, that sounds good. And suddenly I was in a graduate program at DePaul, and I loved it. I loved having an opportunity to be critical and having a voice, and the rest is kind of history.
Amazing. What a story. And that's exactly why I was so excited to speak with you was your lived experience.
Sure.
That is so cool. You actually touched on it a little bit, David, when you spoke about different uses of methadone, or like what are some reasons? I think I was very ignorant of the subject of methadone, but what are some different reasons that people do use it?
Well, I mean, it's almost difficult to parse out even the reasons why people themselves use it, because it's such a top-down system. You kind of have to talk this talk about recovery and about abstinence and about I'm an addict and I want to be in recovery. So whether you kind of believe, and that's tied to your ability to access the medication, specifically in regard to things like take homes. I don't know if of your audience knows, but people on methadone, for the most part, have to go to their clinic every single day. And particularly if you are, using drugs, using even marijuana. There's a lot of diversity about how clinics do this, but in general, if you don't fit the mold of like I'm the good patient in recovery and I'm abstinent from all drugs and all this, that kind of thing, you're going to have a difficult time of being on methadone because they're going to make you come every day. I mean, that right there is a huge problem. So people start to sort of talk the talk, they internalize this narrative, and it becomes difficult to even know what you think because you have to sort of present in this kind of way. But I think in my interviews with people, I've chosen to do my interviews in a rather non-scientific way in my work, because I was like, if I just do this sort of, you're supposed to be kind of neutral as a scientist, and I was not neutral. I didn't want to be neutral, and I felt if I was neutral, I would just get this kind of presentation of, oh, yes, I want to be abstinent, yes, I want to be in recovery. uh and I felt like if I could talk to people in a deeper way by telling them, hey, I'm on methadone too, I use drugs too, that we could maybe get a little bit beyond that. And that's what happened. And it turned out in my discussions with people, sometimes they would start off, oh yeah, I want abstinence, yeah, I want recovery. But then when you would talk to them, it would be much more like, no, I got on methadone because I'm sick of being dope sick, because I can't stand being in withdrawal. I still want to use drugs, maybe. I maybe still want to use heroin even, but I want to be stable. I want to be able to have a job. I want to be able to go to school. I don't want to be in this never ending cycle of waking up sick, having to score money, having to score drugs ad infinitum forever. And so their reasons were like pragmatic, and not only were they pragmatic, they had to do with drug policy. They had to do with the fact that heroin is illegal. A lot of people would tell me things like, hey, look, if I could just stay on heroin and it be legal and I could actually access it in a way that is manageable and I know what's in my product and it's regulated in the same way as alcohol, I'd be on heroin forever, happily. And that's what I say too. I would much prefer to have never had to stop using heroin. Um, and so it really diverges not only from this narrative of recovery, but people are not so much recovering from addiction so much as they are managing prohibition or managing the war on drugs. And people often get on and off. Sometimes people will get on for a while just to like stabilize, because they're like my life is so out of control. I've got to get stable for a couple months, and then the clinics are so poorly run that there's always this incentive to get off, even if it's benefiting you. And I talk to lots of people that are like, oh, it's great, the methadone itself has changed my life, but I can't go to this clinic every day. So it becomes very complicated. But I would say people mostly use it for stability. They want to be stable, they want to live their lives, they want to do the same things anybody else does, and it enables them to do that to an extent.
Thank you so much. That clarified so much for me. Thank you. I I guess I don't know too much about this, David, but if you don't mind, if we talk a little bit about the different types, because I know there's different types of opiates that are available at clinics and probably for different types of people. I'm aware of Suboxone and
Right.
Cadian as well. I'm not sure exactly what Cadian is, but I've heard the name. Can we talk a
Same here.
little?
I don't know what it is.
Okay,
Yeah.
yeah, thank you. But I was just wondering if we could talk at all about maybe maybe the differences between like Suboxone and
Yeah. No,
methadone.
they're important differences.
Thank you.
I mean, the main ones, the main uh, substitution-based treatments are methadone and Suboxone. Suboxone is buprenorphine, with the active ingredient or chemical. That's the opioid. So first of all, buprenorphine, either in Suboxone or Subutex, is less potent than methadone. That's the first thing to know. It's a partial agonist rather than a full agonist, which just means it's less strong. That's really what it means. So that difference right there is important in that, like, some people might not need to be on methadone from a pharmacological perspective because I mean, not that it's too strong, because I oftentimes would say you might as well just go on methadone. But the fact that the clinic system is so problematic that if someone maybe wasn't doing heroin, maybe they were just doing prescription opioids, or maybe they didn't have a habit for years, maybe they were just what we call chipping, using here and there for a while, then maybe you'll be like, look, go with Suboxone, because then you're not going to have to deal with the clinic system. It's less strong, but and that might be good too, because maybe you're going to want to get off it. Whereas like the hardcore types that they're like, I'm never going to live without opioids. They almost have to go to methadone, and just deal with the clinic system. So I mean, that's another important difference. I've referred to it, but I haven't said it specifically. Methadone can only be delivered in methadone clinics, unless you're getting it for pain. Whereas Suboxone can be prescribed from a doctor. And that's huge. I mean, it's monumental how much difference it makes. And the way it mostly plays out is that you don't have to go every day. So Suboxone, you get a script, you get it in a pharmacy. You maybe have to go in once every month or every 3 months to check in with your doctor. Whereas methadone, every single day. So some people have to get on methadone, even if they're like, I would do better on, or they have to get on Suboxone, even if they're like, I would do better on methadone, because I can't go to the clinic every day. And sometimes that leads to terrible things. Like people are like, oh, it's not really working. I'm still using and bad things are happening. So the pharmacological differences are Suboxone is less strong, less potent, and the delivery differences are methadone's in a clinic, whereas Suboxone's in the doctor's office, or could be in a clinic too, but it could be in the doctor's office. And that plays out in all kinds of crazy ways. But those are the differences.
Thank you so much. And perhaps because this, to be honest with you, this boggles my mind a little bit, but does that explain why, unless I'm wrong, methadone is the preferred go-to out of the two for pregnant women? Is it because of that ongoing monitoring that, I mean, I've read that methadone is
I mean,
actually superior to Suboxone in pregnancy.
well, usually method they recommend methadone for pregnancy just because they don't want to take any chances. It's more potent, it's stronger, and so that I mean, I don't. That's not my area of expertise, but you don't
Right.
want the baby to go into withdrawal, and which could lead to horrible things. So yeah, I mean, I think maybe. I don't know that the monitoring would be a part of it, because they could monitor you on Suboxone that well. And it's not like you're really receiving any actual health care when you go into the clinic every day. It's more like surveillance rather than like health care. But I think it's just because they don't take any chances. Like if you're pregnant, they also will not make you wait on the waiting list to get in often. They'll make things a little easier. Sometimes they'll even make things easier with take homes, although oftentimes they don't. I remember interviewing a woman last year. She was homeless. She was pregnant. It was winter, and her clinic was like 2 hours away, and they made her go every single day. And
Wow.
it was like, this is insane. So yeah, I think it just has to do with the higher threshold of methadone for as an opiate agonist.
Thank you so much. And for anyone watching this who may be thinking, oh, I should go, I should talk to somebody about methadone or about opioid use disorder medications. And maybe they were on something, maybe they were on something harder. Are there any are there any reasonable cons that they should be aware of? I've heard something to do with like teeth, but I don't know how true that is. Is there any downside at all other than so much time in the clinics?
There are tons of downsides, but they're mostly about the clinic,
Okay.
not just the time in the clinic. Well, you're treated like crap in the clinic. You're treated like an absolute child. And this partly has to do with the way we conceptualize drug use through this narrative of addiction, which is something I'm very critical of. But you're treated like an addict, and you have to do what they say, and they you have to, I mean, not only do you have to go in every day, but you can't like leave town, like you can't like say like, oh, I'm going to a wedding in LA next week, can you give me some take-home medications for that? Like, you won't even, forget it, no way. It's incredibly paternalistic. You surrender complete control to these people that know oftentimes very little about drug use. They're often far from your house, so like not only do you have to go every day, but it's far that you have to go every day. Yes, so there are downsides. They control everything, and there's also variance. I mean, I go to a clinic that's better, like and there's also changes in the laws which made things a little bit better. But when someone, even if I think someone would do better on methadone, would do well on methadone, and from a pharmaceutical standpoint, that's definitely due. I always be hesitant and warn them. Like, this is a big commitment. You're committing not only to having to go to this horrible clinic every day, and because you'll definitely have to go for like the first 90 days, even though they'll say now. But you'll be getting more because you will get your own every day. Like when you're using heroin on the street, the fact that it's hard to get oftentimes keeps you from getting a real tolerance. Like, you get dope sick sometimes and your tolerance goes down. Whereas on methadone, you're getting it every morning, 6 a.m. Boom, I take 100 milligrams of methadone every day. So like, I couldn't just walk off the clinic right now. I'd have to slowly go down, titrate over like a year or two, just to be able to do it with any level of comfort. So yes, you're committing yourself to being physically dependent, not only on a medication, but on a terrible system. I think people only should go on methadone if they have to. And but a lot of people have to. That's the rub too.
Right, right. Well, on that note, over the long term, are there are there any other benefits aside from sort of the immediate ones? Is there any evidence or what have you that shows that there can be some positive things for depression, for for anxiety, for
Sure.
PTSD?
Absolutely.
Wonderful.
Yes, and I don't know how well the sort of randomized control samples. I don't know if they show that as well, but certainly my work is qualitative. I mostly interview people and talk to people and compare themes and things like that. And absolutely, people talk about how methadone, or opioids in general. I think it's kind of helpful sometimes to not distinguish so much between opioids. But they definitely say, hey, when I'm taking opioids every day, I feel better. And they don't just mean in like an intoxicated way, because opioids aren't even that intoxicating. They're just like, I feel good. I feel happy and stable, and I could want to do things, and I'll clean my house, and I can go to work, and all of these kinds of things. And I wrote a paper that was criticized quite a bit, and is still criticized quite a bit, that argues that methadone, rather than a way to get off drugs, is actually a way to get access to them. Uh, because it's so difficult to get heroin on the street, uh, and they benefit from taking heroin, pharmacologically, anyways, not from the drug policy. But people are really going on methadone, not so much because like I want to get off drugs, but because I want stable access to regulated opioids, and that's what methadone provides. They call it treatment, and it's all wrapped up in that label. But I think what it really is a way to get your opioids outside of criminalization. Get them legally, get them regulated, and there's not going to be xylazine in it. There's not going to be fentanyl in it. You know how many milligrams you're taking. You're not have to worry about your dealers not going to be there. So yeah, people benefit from opioids. A lot of people do well on opioids. We make these ideological distinctions between, oh well, you're a pain patient, you're an addict, you're this, you're that, and I think most of those are very superficial.
Right.
Some people like opioids and benefit from them, and we look for different kinds of classifications that make it easier to gain access to them.
Thank you. That's beautifully, beautifully said. That I just my mind's just blown right now. I've learned so much.
Yeah.
Wow. Um, so is this type of work, is this something that how can I say this? Would the average person, in your opinion, this is just going off subject just a little bit, but it's something I've been curious about, disclosure. Now, should the average,
Mm.
is there consequences to the average person for, say, disclosing to an employer or something to that effect? Can
Oh,
there be consequences to it as well?
absolutely. And that's one of the things that makes the fact that you have to go wait in these lines and not know how long you're going to, even more on your ability to hold a job. Because not only do you have to go somewhere at 6 a.m. every morning, not only do you not know how long you're going to be there, and have no control over that, but you can't tell your boss in most cases, hey, I'm late because I was at the methadone clinic, or you can't call them and be like, oh, the line's longer than I anticipated, I'm going to be a little bit late. Because of the stigma. Because I
Yeah,
mean, not every boss, clearly people have different views, but
sure,
it's a certainly people are definitely afraid of loss, and they have good reason to be.
sure,
So yeah, that's a huge problem. I know plenty of people that don't tell their families. I know
of
people that
course.
don't tell their significant other. Uh, I mean, you get other people like, I mean, myself, I was always public about it. I'm especially public about it now because I have a degree, and that sort of changes how it's perceived. Although not that much. Well, I mean, it does a lot, but I'm still marginalized. I mean, even my job, I'm a research scientist at New York University, and I definitely am on the I get screwed all the time. Like they won't let me teach, because they're worried that some student's going to say to their parents, my teacher's on methadone or something like
Right,
that. And NYU doesn't want that. I mean, I've when I was getting my PhD, I had to teach often just as to get my stipend, my financial aid. And not surprisingly, students loved having a professor that was on methadone, and they had a million questions that they couldn't ask anyone else. And younger people tend to like authenticity, and they loved having, I taught like drug use, or I taught sociology of drug use or drugs in society, classes like that. And it was wonderful. And it just pisses me off to no end that NYU won't let me teach because I'm on methadone. And they of course won't say it's because I'm on methadone.
right.
But yeah, it's a very stigmatized medication. And
Yeah,
people that use drugs are stigmatized in general.
100%, 100%. Um, David, I'm curious from your perspective, if you could, if you could change things, right away with the clinics, what is it that you would like to see from your perspective change with these clinics or with the policy of them?
Okay, I have multiple answers for that. First, I always like to say that I think all drugs should be legal and regulated. I mean, that's what all of our problems right now with overdose are having. People aren't dying because of addiction per se. They're dying because there was something in there, the medication, whatever drug, medication, the substance that they took that killed them. That was not what they wanted. They wanted heroin. I mean, now people it's gotten more complicated with fentanyl, but it's because they don't know how many milligrams of something they're taking, and they don't know what else is in it. And therein lies the problem. We like to talk about it through this very medicalized language, but it's a simple problem of not regulating the supply. If I sometimes say, if 1 out of every 6 beers had cyanide in it, we wouldn't talk about like people need treatment. People, they're alcoholics. We would be like, we need to get this poison out of the beer. So yes, I think we need to legalize and regulate this product. But if you want, that's not going to happen. We know that's not going to happen in the United States. So I would like the clinic system to lose their monopoly on treating people with opioid use disorder. Right now, as I mentioned, you have to go to a methadone clinic. You can't go to your doctor like people on Suboxone can. So there's a bill called MOTA, the Expanding Methadone Treatment Act, in Congress right now. I don't think it's going to pass, but that's what it would do. It would essentially say like you can also it would enable addiction doctors to prescribe methadone. That would be a wonderful thing because that would give people choice. There are people that like going to the clinic. I talked to them in my research. There's various reasons for that. Sometimes they're like, oh, it keeps me on track. Sometimes they're like, I see my friends at the clinic. Sometimes there's all kinds of reasons. And it's a minority. I think most people would be like, get me out of that clinic. I'm going to the doctor. Uh, but the bill would enable for both. So that would be my sort of second choice. Um, and my third choice, because I don't think the Moda bill is going to pass either, would just be if clinics would change their ideology and follow the actual evidence and science that most people who are using and benefiting from methadone do not buy into these ideological constructs about like I'm an addict and I need recovery and abstinence and all that. They're using it for simpler to understand reasons. And the fact that we don't understand that leads to like, well, I don't know if you know this, but retention in methadone is about 15% after like, if you try, it's hard to add up the total population of people that use opioids or whatever, but everybody drops out. Nobody stays on at like 1 year, like retention rates are like 45%. And that's because it's such an onerous, awful system. If we were to like be like, look, people are just looking for an easier, regulated way to get their opioids. Maybe they want abstinence. Maybe they just want to reduce. Make it individualized. Make it available to people with different goals rather than complete abstinence from all drugs, because it just leads to people not doing it or getting, some people get kicked out. Most people leave of their own volition. But yeah, I think treatment needs to be, it needs to be structured in a way to meet the actual needs of the patient, not the imagined needs of the patients due by the providers, which is how it is now.
Well said. Well said. And I think you actually just answered one of my questions in what you said. Wow. So my question was how long, sort of the average person is on it. And I was thinking like
Right.
decades, but you actually just answered that by saying there's actually a low retention rate. But for those who do succeed, how long are they? I mean, could they be on it for
Well,
decades?
yeah, I've been on for 20 years. I've been
Excellent.
on methadone for 20 years, and a lot, and it has a lot to do with whether you could find a provider that will make it feasible. Like the only reason I've been on for 20 years is because I do get take home doses. I go in once a month, and I pick up my thing of methadone in a prescription bottle, and I take it home, and I just take it every day, and then I go back in a month. Like without that, there would have been no way. In fact, when I was moving from Chicago to New York to start my PhD program, I was terrified because I'm like, my God, I know how bad the clinics are, and I'm like, I'm not. There's a very good chance they could not honor my take homes, which I had in Chicago, and they might be like, "No, dude, you're coming in every day," because there would have been no way. I would have either had to stop the program or the program, my graduate program or my methadone program, and it's often a horrible choice. Someone I interviewed for my dissertation moved from, he was getting take homes at Chicago because they were a harm reduction reasonable clinic. Uh, he smoked marijuana, but he had completely stopped using heroin. Completely stopped using heroin. He was like a 22-year-old kid. Also, he gets a good job in Cape Cod, moves to Cape Cod, but there's only one clinic there, and they're very conservative. And to them, he's still not clean, even though he's completely stopped using heroin and he just smokes pot and he's like a 22-year-old kid. They're like, oh, that's addict behavior. You're coming in every day. And he's like, I just got this new job. I can't come in every day. I can't tell my employer, my new employer of this good job I'm on methadone, and I can't go to the clinic every day. And he called me like crying, and he's like, what am I going to do? I'm going to have to quit one or the other. And he ended up quitting the methadone clinic because he's like, I worked hard for this job. I got off heroin for this job. Uh, but after having quit the methadone clinic, then he knew he had to go back to heroin because he would have to get it off the street as his maintenance drug. And he died, in 2 months. He was dead
Oh boy.
of a fentanyl overdose.
Oh boy.
So,
That's
yeah.
heartbreaking.
How long you stay, I think most people would stay on a long time if treatment was manageable. And certainly results are far better. And it depends how you measure results, but if you measure them like reduced rates of overdose, reduced frequency of drug use, ability to hold a job, ability to go to school, the longer you're in, the better those outcomes become.
Thank you. Thank you. And how does somebody who say they're doing an undergrad right now and they're fascinated by this conversation and they want to study what you study, how does somebody even get involved in the field of medical sociology? What would you
Well,
recommend?
medical sociology, I mean, isn't just about drugs. And
Right.
a lot of times does involve drugs, but it's any. I mean, I initially got on it because, or into medical sociology, not so much. Well, my drug use later became a big thing, but just because my brother, I have three younger brothers, and the one that's 2 years younger than me, when we were growing up, he constantly had problems. They weren't drug problems. He was the only one of my brothers that never did drugs. But he would constantly go to different psychiatrists and get different diagnoses. And it was like bipolar, fibromyalgia. I just one through the other over the years. And it was very clear to me that while there may have been actual medical things going on, there was also very social things going on. Like my brother was using he would like triangulate the his psychiatrist against my parents, against him, and they would there was a lot of manipulation going on. This was not all just a neutral diagnosis of someone's mental health. There was a social aspect to it. And I think anyone that's skeptical of medical diagnoses, of the way the medical world understands the world. They tend to ignore things like race. They tend to ignore things like class. They ignore structures in general. The medical gaze is a gaze on the individual body, and not all the stuff that goes around that the individual body exists within. And anyone that sort of is motivated to interrogate those systems, I think would do well in medical sociology. And the way to get into it is just to take those classes, I guess, or to major in it, or at least to take sociology classes. If people are more interested in things like methadone, there's certainly a lot of like drug user advocacy going around and harm reduction advocacy, and there's a lot of like groups, and you don't have to be someone with lived experience, although that it often does benefit if you have some sort of connection to that world. But if people just are there for purely advocacy reasons, that's great too. I'm a member of a group called the National Coalition to Liberate Methadone, and we're I think the only group that has people on methadone, treatment providers, researchers, and advocates, and we have a very non-hierarchical kind of approach. So yeah, the methadone is actually a big topic right now. Well, overdose, everything to do with opioids is a big topic.
Yes.
So yeah, we could use all the help we could get, and I would
Amazing.
encourage anyone to be critical of the medical world. There's so many ways of going at it, and things to pick at. Yeah, you'll never run out of stuff to get annoyed about.
That's funny. I have to ask as we're getting ready to wrap this up, David, I have to ask, is this type of advocacy, is this the future of your work? Is this what you want to keep doing?
Oh, absolutely. Yeah,
Amazing.
I'm not a person that could like compartmentalize. In fact, I think that's one of the reasons that my heroin use got so chaotic in my later 20s, because I'd recently got married, and I didn't know what to do. I had like nothing. I mean, I'd been in like I played in like bands as a kid, and I sort of a little bit aged out of that. Not that I couldn't do that, but I was never going to make a living doing that. So I had to think of something that I was going to like make a living, and I just didn't want to do anything that I didn't want to do. I wasn't going to go sit in a cubicle and work for some company. And so in a weird way, like getting having a really difficult, chaotic experience with drugs gave me an occupational identity, something I could do that was meaningful to me, uh, that I have continued to do since then. So there's a lot, and there's a lot to do in the drug user space. It's not just methadone, although that's the focus of most of my work. There's also safe supply and overdoses and the overdose prevention center that recently opened in New York, and just all kinds of things. And I think studying drugs is a great way of doing sociology because it's a door to culture and views and the way our society is organized. You could talk about race, you could talk about class, you could talk about education, all kinds of things. Drugs are a nice window into that. So yeah, I'm certainly going to continue in the same direction to the extent of, well, I was going to say to the extent that I could keep my job, but I guess even if I can't keep my job, I'm going to still continue in the same direction.
Fascinating. Thank you so much for the work you do. That I mean, this has just been just a fascinating conversation. And before I'm going to say goodbye to you after we stop recording, as I mentioned, but before I let you go, where can people you mentioned advocacy group that you're working with. Where can
Yes.
people find you or follow your work if you do that
I could.
publicly?
Is there a chat? I could put like I could put my email in the chat, and I could also put the website of the group I mentioned in the chat.
You know what? I
Is
don't
that
think the
easier for you?
chat. I don't think they see the chat, but I can put it if you send it to me. I'll put it in the description box of the video.
Great.
Absolutely.
I'll do that then. Yeah.
Okay, thank you so much. Thank you. This has been just a wonderful conversation. I've learned so much. I'm just blown away, and I can't thank you enough for the work that you do and for all of the people that you're helping.
Well, thank you for having me, and thank you for covering this very important topic. So
Very,
thank
it's
you.
very important. Thank you so much for your time today, David.
Great.